My name is Dr. Christina Peroutka, and I'm one of the geneticists at UVA, and it's a tremendous honor to have been asked to speak with your group, so thank you so much. And the first part of my presentation actually is not about genetics because the diagnosis of hypophosphatasia does not require a positive genetic test. So even though I'm a geneticist and I send genetic testing all the time, that's one of the biggest learning points that I want this audience to take away today. And then, of course, the second part of my presentation will go into the intricacies of genetic testing for patients with HPP. So, as I mentioned, number one, it's important that people just recognize the presence of low alkaline phosphatase as a key biomarker for this condition. We'll also just briefly review the causes of low alkaline phosphatase and the differential diagnosis. And the different causes specifically related to the enzyme then overlap with understanding the genetics. We'll also go into the inheritance patterns and recognize that HPP can be present even with negative genetic testing. And then finally, not that I work for any particular genetic testing company, I just like to share very practical information about how you can go about getting genetic testing for HPP. I'd also like to start with a few patient cases. Of course, these have been adapted from patients, so aren't exact mirrors of people that I see, but illustrate key points. So the first patient is of a 60-year-old who presented to me as a second, requesting a second opinion for management of low bone mineral density or osteoporosis and chronic back pain. And recently she had reported a loss in height and had developed chronic back pain after a severe respiratory illness and cough that became persistent. She had always been a very active patient, but now struggled with limited mobility, so had difficulty specifically with standing or walking even more than half a mile. And she had pretty chronic neuropathy symptoms. When we reviewed her medical history, she had lost teeth before kindergarten entry, which is unusual, although, when she came to me, she wasn't sure if the roots were intact, as you saw in the photo from Dr. Jean DeBoer. She did wear glasses, but didn't have any known corneal or other eye calcification, didn't have a fracture history, and that's especially pertinent given the presentation of osteoporosis. And when you look at her family history, not that you have to see the fine print, I just want you to see colorful blocks on both sides, both coming from her mother and her father. And why I mention that is because, again, she came to me for a second opinion for osteoporosis, and that was present on both her mom's and her dad's side of the family. And I would also argue, right, that that's a very common condition in the general population. Her father in particular, though, had additional features of poor dentition, did have a history of oral cancer, but notably his poor dentition concerns had occurred before that. And then she also has a niece who has chronic pain, but no other obvious specific symptoms that would be concerning for HPP. So when we did a comprehensive lab evaluation for this patient, when you look at her history, she had had persistently low alkaline phosphatase. She had an elevated B6. She did not have any other cause of low alkaline phosphatase on labs, and her endocrinologist had raised concern for HPP, prompting the referral to me in genetics. So we helped send genetic testing, and for this case, the lab did call a disease-causing or pathogenic variant. She just had one variant. In terms of other evaluations, she didn't have medullary nephrocalcinosis or calcium in her kidneys. She didn't have calcium in her eyes. She had very, very rapidly progressive osteoporosis, which is unusual because Normally we do DEXAs every few years, and she had had a greater than 10% loss in 1 year. She was living with very severe pain that was interfering with her daily living, and then on physical therapy assessment had differences in mobility and strength. And then she was doing okay with the brief walk test. This patient did go on treatment, and you can see her pain just dramatically improved. And importantly, even though she had a strong family history of osteoporosis on both sides of her family, was starting acetase alpha that stabilized her bone mineral density, and she's continued to not have fractures. So the pearls from this case are that genetic testing did help confirm HPP in this patient with a strong family history of an otherwise common disorder. And to the points that Dr. Jean DeBoer made, it helped in appropriately managing her low bone density, because this is not a patient who would have benefited from more common bisphosphonate use. The second case I wanted to go over today is a patient who was a young woman. She had been diagnosed with hypermobile type Ehlers-Danlos syndrome. She also, by age 30, had low bone mineral density, poor dentition, chronic pain. And I mention this because hypermobile type Ehlers-Danlos syndrome, some of you may have that diagnosis or may have heard of that diagnosis. But basically, that's somebody who, on a scale of 9 joints that we're looking at for hypermobility, has 4, 5, or 6 of those joints that are too hypermobile. So they move more than they should. There's no known gene for this condition. These patients often have chronic pain, often have other musculoskeletal symptoms, often have low bone mineral density. And so I point that out because people will just throw this bucket diagnosis out. They don't really look any further at their labs or their clinical history. And there are a number of my patients who have hypermobile type Ehlers-Danlos when a more specific diagnosis would have been hypophosphatasia that would have opened the door to a treatment that could have made them feel a lot better. So this patient specifically, when you think about her history, already in childhood, she had difficulty growing, she had fractures, she had frequent cavities, she had chronic muscle and joint pain as a child, difficulty walking, she was more tired than her friends, couldn't keep up with them, she had chronic headaches, brain fog, confusion, and as an adult, she went on to have severe bone pain and then this diagnosis of hypermobility. And this patient, it was actually her cousin who was also diagnosed with Ehlers-Danlos syndrome, saw a physician who said, "No, I think you have HPP." She contacted my patient and said, "I think you have HPP." And then I also, in family history, wanted to point out that this patient does have children who have normal alkaline phosphatase levels for their age and sex. So here again, persistently low alkaline phosphatase, high B6. The urine phosphethanolamine was negative or normal. I do often see normal B6 or normal urine studies in my patients. It doesn't negate a diagnosis of HPP. And this patient had negative genetic testing. Imaging studies overall were unremarkable aside from low bone density on DEXA, also lived with chronic pain. And so in summary, this is a case, right, where it's important to look at a patient comprehensively, look at their labs, make sure they don't have another reason. But this patient qualified for treatment, started treatment, and has had significant benefit from receiving a diagnosis and having access to therapy. So the other pearl that I just really wanted to hit home on for this case is the family history. So this is a patient, right, who has negative genetic testing. So I can't send genetic testing for her children because if they also have negative genetic testing, it doesn't mean anything because the patient's testing was negative. And so it's important then for her children to look at their alkaline phosphatase levels with the lens of if they were a little boy or little girl, and then how old they were when the testing was sent. HPP is fundamentally, right, a congenital genetic condition that you have that's present since birth. And so if you have consistently normal alkaline phosphatase levels, that would rule out a diagnosis of HPP. And so her children do not have HPP. They will never have HPP. So the pearls here to summarize are that the diagnosis of HPP is made in the setting of persistently low, otherwise unexplained, low alkaline phosphatase enzyme, period. And then genetic testing is positive or negative. It's negative in about 5% of cases. If present, it would affect your alkaline phosphatase levels from birth. And so in cases of negative testing, a normal alkaline phosphatase would exclude a diagnosis in a family member when you can't send the genetic testing. So now I'd like to just briefly go over hypophosphatasia, the disease definition and the history. This point I've said a number of times already. The gene is from disease-causing changes in ALPL, which in some literature you'll see noted as TNSALP, which is for the tissue nonspecific alkaline phosphatase. It can be a dominant or recessive condition. It is considered ultra rare, and historically we think that the severe forms are only present in up to 1 in 300,000 people, but more and more we recognize that this is a very underdiagnosed disorder. Basically, the time that it took to recognize alkaline phosphatase as being important in bone mineralization in 1923 to actually having a treatment available was almost 100 years. And so I just want to point that out because it's so important to recognize these patients and be able to provide them a treatment when it's appropriate. So now let's talk very briefly about the enzyme and the structure. So hypophosphatasia is specifically due to deficiency in the tissue nonspecific alkaline phosphatase, which makes up about 95% of total alkaline phosphatase activity. And why I mention this is because alkaline phosphatase is very commonly ordered by clinicians as part of what's called a comprehensive metabolic profile. So often, right, if you notice a low alkaline phosphatase, you can go back in that patient's chart to when physicians otherwise ordered CMPs or comprehensive metabolic profiles for other reasons. And I'm about to talk about why there could be false elevations of that. But by and large, when you look at the alkaline phosphatase on that metabolic profile, you can know that 95% of that is going to be tissue nonspecific alkaline phosphatase and therefore pertinent for patients with HPP. There are other tissue-specific alkaline phosphatases in humans, and those are germ cell, intestinal, and placental. I think the two that are pertinent here are if you do have GI disease affecting your intestines or liver, you can have false elevations of alkaline phosphatase because of the relative contribution of this isoform. And likewise, if you check levels in women who are pregnant who have HPP, their levels can be normal or look normal because of the increased expression of the placental isoform. So above and beyond what would have been made by the gene for tissue nonspecific alkaline phosphatase. Tissue nonspecific alkaline phosphatase is present in all tissues, as Dr. Jean DeBoer mentioned, but it's most abundant in bone, liver, kidney, and developing teeth. And this is really why we see a lot of the disease manifestations that we do. But it's also important to recognize that the relative proportion of expression from bone and liver is what drives the age and sex-specific cutoffs, because when a child is supposed to having a growing skeleton, the relative expression of bone-specific enzyme is going to significantly increase. And then it falls when you're done growing. And the other thing that I'm just going to begin to touch on here is this fancy schmancy little picture of a homodimer. So this enzyme doesn't just function independently. Number one, it has to buddy up with another exact copy of the enzyme. And then you also see that there are all these important domains, the crown domain, the active site, where it binds to magnesium, where it binds to zinc. And that's all important when we think about the laboratory and genetic mechanisms of this condition. So I'll actually just skip to here. And Dr. Jean DeBoer talked about this in her presentation. But essentially, if you just look at the lower limit of normal for boys and girls, the cutoff for adults below which you would be concerned for HPP is 40. But if you have a young patient, who's 9 years old, and they have a level of 140, it's just important to know, well, that's a lot higher than 40, but it's still way too low for where that child should be in terms of alkaline phosphatase activity to support a growing skeleton. Okay, so now let's switch to making the diagnosis of HPP. And this slide, I wish I hadn't put animations on, number one. Essentially, there's a lot of reasons for low alkaline phosphatase, but when you send the lab evaluation, which Dr. Jean DeBoer had included my slide of my list that I like to send in patients, essentially, don't be overwhelmed by this slide, because when you send that list of labs, you're basically ruling out those other things. And you're looking at your patient or looking at your family member, you're reviewing their medication list. So it's not actually that hard. You just want to make sure that the patient, doesn't have nutritional concerns that need to be addressed, because again, this is a homodimer. It has to bind magnesium to work. It has to bind zinc to work. If you don't have magnesium or zinc because of nutritional reasons, you could have low alkaline phosphatase and not have a genetic cause of that, or the primary disease. Okay, and then the other thing that I just wanted to point out here is that there are a number of other disorders that cause soft bones, but the hallmark feature is that you have low alkaline phosphatase and HPP. So again, it's very straightforward, very easy. And then this was the slide that Dr. Jean DeBoer already showed in her presentation of how I approach patients. And so with that being said, we can talk about the genetic testing. So what we know about this particular gene is that the spelling of the gene is what's called highly conserved. And so what that means is that over time, that enzyme has been used in a number of animals and other species in order to harden or calcify bone. And any spelling differences in that gene are really going to cause a problem with health. So whether you talk about other animals or humans, we just know that we're all sort of spelled very similarly when it comes to alkaline phosphatase. We know of over 400 ALPL variants, and the number of variants is growing and growing. Even within my own patient population, I have a number of patients who have uncertain variants, and we're able to get that variant classification upgraded when we show other family members who also have low alkaline phosphatase and symptoms of HPP. So it increases the level of evidence around that variant. We also know that there can be what are called sequencing, deletion, and duplications that cause HPP. And what does that mean? So a sequencing error is if you had a spelling mistake. And then a deletion error is where you have basically a missing piece of the gene, where part of the gene was just taken away. And a duplication is where you have an addition to the gene, so where there are extra letters added. And in humans, when we read our genetic information, our genetic information is organized in 3 base pairs at a time. And so particularly where deletions and duplications can be problematic is if you don't delete or duplicate something in a multiple of 3, well, then you make the rest of the word or the gene jumbled and you can't read it because that grouping gets sort of offset, if that makes sense. And we also know that genetic testing right now identifies at least one variant in 95% of cases. As I mentioned previously, this can be recessive or dominant, and I'll talk about what that means. And there are loss of function and dominant negative effects. I'll also talk about what that means. So in terms of variant classification, there are currently 5 ways for a lab to classify a variant. And I really emphasize the word for the lab to classify a variant because the reality, right, is that most humans in the world haven't had genetic testing. And even in the humans in the world who have had genetic testing, those are primarily people who are Northern European in ancestry or people who live in the United States, or maybe certain populations, like if you're French Canadian or Amish or Ashkenazi Jewish. We just happen to know a little bit more about certain populations who have been, more able or willing to get genetic testing. And so at the same time, it's just important then to recognize that humans across the world were all spelled a little bit differently. And so we're all different heights, we have different hair color, we have many differences that are readily apparent on the outside, but the same is going to be true for everything on the inside. And so we're all spelled a little bit differently when it comes to our biochemistry and our way that our body works on the inside. And so alkaline phosphatase is a gene that encodes an enzyme, and each of us is going to have probably a slightly different enzyme activity. And so then the question is, well, how much evidence when we see a spelling difference do we have to say with clarity and with certainty, do we know that that spelling difference is going to cause a problem with health or not cause a problem with health? And in the United States and in Europe, there is very strict variant classification guidelines that put weight on criteria. So how rare is that variant in the population? Remember, we talked about the fact that ALPL is very highly conserved, so variation is poorly tolerated. So if you have variants that really aren't seen among humans, that would argue that that's more likely to cause a problem with health or be disease-causing. Whereas if you see changes that are very prevalent in a population, that could argue that that's benign or not disease-causing. And so, likewise, the labs are going to consider, has this been published before in individuals who are diagnosed with hypophosphatasia? Does it track in a family this spelling difference among people who have low alkaline phosphatase, and is it absent in members of that family who have normal alkaline phosphatase? So with all that being said, there's weights and grades given to each variant, and ultimately the lab has to make a call. So they can say with certainty, there's no question this is disease-causing or pathogenic. Here, though, it's important to distinguish between recessive or dominant conditions, and hypophosphatasia is a more complicated because it has both recessive and dominant presentations, and so we'll talk about that in more detail. Likely pathogenic, if you've seen that on your report, means that there is a lot of evidence arguing for it being disease-causing, and the lab is about 90% certain, but they just can't with more certainty say that it's pathogenic. A variant of uncertain significance is truly on the fence. It just means that that lab does not have enough evidence right now to say with certainty, does this cause a problem with human health, or is it just normal variation? And then there's likely benign, where they think most likely it doesn't cause a problem, and benign where it's clearly not disease-causing. So now let's talk about what it means to have dominant inheritance. So in this diagram, the father, or the man in teal, is affected, and he has one copy that's changed, so the teal copy, and the purple copy that works, and then his partner has 2 copies that work. And so each time this man has a child, there's a 50-50 chance of passing on the copy that works or the copy that doesn't work. And it's agnostic to whether he's going to have a little boy or a little girl, right? Because it's not on a sex chromosome, it's on an autosome. And so essentially, then his partner, who has 2 working copies, would just pass a working copy. And so that's where you get the 50-50 chance of transmission with each pregnancy. And here, just for purposes of illustration, right, they gave examples where the father passes the not working and the mom passes the working. They both pass the working, and the mom passes her other copy of the working for the other one. And then the last picture where, again, a parent passes a not working and working. But I point this out that it's a 50% chance with each pregnancy, because we certainly have families, right, where the second pregnancy comes along and the child is affected. The third pregnancy comes along and the child is affected. So it's just important to recognize that this risk starts over with each subsequent pregnancy. Okay, and then this is compared with autosomal recessive inheritance. And here, the mother and father are not aware that they carry a change in the ALPL gene. And again, the father could pass the copy that works or doesn't work, and the mother likewise. And the possibility that both parents would copy or pass a copy that doesn't work is 25% with each pregnancy. And so this is just a slide where I put both side by side so that you can see the difference in risk of transmission. So how do we wrap our heads around the fact that there's one gene, there's 2 inheritance patterns, and then historically there are 6 forms of disease? And what do we do with all of that? It seems really complicated. The reality, though, is it isn't as clear as just 6 forms and 2 inheritance patterns. What we see, right, is that especially with people moving all around the world and our genetics blending, that you could have a loss of function variant and a dominant negative. You could have 2 severe loss of function variants. You could have just 1 loss of function variant or 1 dominant negative. And so there's all sorts of combinations of genetic changes that are combining. And what we really more so see is that there's a spectrum of disease presentation. I follow at this point over 50 patients with hypophosphatasia, and I'm really beginning to question if there is such a thing as adult onset disease. And the reason why I say that is because when you really look with a fine-tooth comb at that patient's history, you find that maybe they lived with chronic pain or chronic fatigue and they didn't recognize that that was abnormal. Or, they lost their teeth before kindergarten and they didn't recognize that that was abnormal. But then the more they've developed symptoms and you look back, you realize this person, again, it's a genetic condition. They were born with it. And oftentimes they have had symptoms starting in childhood. And this is a slide, again, Dr. Jean DeBoer and I are reading all the same literature here, but some features are going to be more specific for childhood onset presentations, right? The rickets, if you're growing, you're going to get the bowing in your lower extremities. Often things like B6 dependent seizures are more specific for infants because those are individuals where the B6 really can't cross the blood-brain barrier, and I would say that's the most severe neurologic presentation. But most of my children and adults with this condition also really complain of severe migraines and brain fog, and all of that improves when they go on treatment. I think that's just a less severe manifestation of less B6 being able to cross the blood-brain barrier. And then, of course, things like osteoporosis you think of as being more adult-specific. But again, what I will say, right, is I now do DEXAs in children starting at age 10, and we're already seeing osteoporosis in children. That's unusual, right? A child shouldn't have that poor of bone mineralization. So here I use this little diagram of kids doing a three-legged race because that's how to think about the enzyme and how it works, okay? So essentially, you can have decreased production, so you can have decreased teams of people out on the field trying to do a three-legged race and get the activity done. You could have the right number of teams on the field, but maybe they have decreased function. You know, maybe somebody has like a sprained ankle or something, or they can't run as fast for some reason. And then dominant negative variants, just think of this little girl who's fallen down. Her partner is perfectly able to work on her own, but when she's tied to this little enzyme who can't work at all, she also can't do her job. Okay, so that's what a dominant negative variant is. A dominant negative variant is where that copy of the enzyme not only doesn't work well itself, it impacts the copy that could work. Now, both can't work, okay? So hopefully that makes it a little bit more clear. And then this diagram here I included because it really illustrates, this is an old paper, relatively speaking, from 2017. But it really illustrates the spectrum of hypophosphatasia instead of 6 distinct categories. And I just put at the bottom some examples of genetic changes that would cause a particular presentation. So if you have one dominant negative variant, that's probably going to present with later childhood onset or adult onset. But also because I've heard a number of people talk about what it means to be a quote-unquote carrier. Even if you have one severe loss of function variant, you could reduce your enzyme below 40 if you're an adult, and you could still meet the criteria for having hypophosphatasia. And that's why the first part of my presentation, I really focused on the fact that hypophosphatasia is diagnosed in individuals who have low alkaline phosphatase activity that's otherwise unexplained. You may have one variant, you may have 2 variants, you may have no variants, okay? And then likewise, remember we talked about the blending of populations and the blending of variants. You could have 2 parents who each have one change, and again, when those 2 changes combine, it produces more severe disease. But it doesn't negate the fact that you also have to look at the parents. Because if the parents have low alkaline phosphatase activity level, even if they have less severe disease than their child and only one variant, they should also receive a clear diagnosis of hypophosphatasia. So I hope that's clear, and if there are questions that come up about that, please don't hesitate to talk with me afterward. On that note there, I will say that there are people who I do think are carriers of HPP, and that's because they have just one disease-causing variant, but when you look biochemically at their alkaline phosphatase is normal. So those people, even though they have a genetic variant, they don't have HPP. Again, because that fundamental defining classification that I gave at the beginning of this presentation. So you really have to look at the alkaline phosphatase activity level. Okay, and sorry, one other thing I just wanted to point out, minor point. ALPL is now on what's called expanded carrier screening, which should be offered to every woman in the United States of childbearing age. And this is tricky because often these women, go to an OB to establish care when they're pregnant. And remember what we talked about, that the placental isoform can falsely elevate total alkaline phosphatase activity level. And so you have women who are labeled as carriers of HPP. They may look at an alk phos when it's falsely elevated, and they may incorrectly tell that woman, you're just a carrier of HPP. When the correct thing to do, anyone who has at least one change should have, other reasons excluded for low alk phos, and then also check an alk phos outside of pregnancy to get a more accurate read on their actual risk. Okay. Now, what do we do with patients with negative testing, and why could you have negative testing? So this is just one paper that came out of note. It was a paper that came out of China that really looked at the fact that people with Chinese ancestry have different variants than people of Japanese ancestry or of Caucasian ancestry. We also see here, just like we see in other populations, that the variation in ALPL is very poorly tolerated. These are all examples of variants. They're spread throughout the whole entire gene. So no matter where you have a misspelling, it's not well tolerated. The gold boxes in this diagram are what we call exons, and the purple line is what we call introns. And so what does that mean in layman's terms? I always like to tell my patients that reading genetics is like reading a page in a book. So right now, when we do genetic testing, we're reading and sequencing the black letters. But just like if you were to read a page, you can't just throw letters down. They have to be organized. And so it's not just the order of the letters, it's those white spaces and the organization of those words on the page that helps us make sense of what we're trying to read. And so in humans right now, by and large, the sequencing, deletions, and duplications that we're looking at are looking for changes in the black letters on the page. But we know that the white spaces or the intronic regions are also important. And so in the 5% of patients who have negative genetic testing, the question is, do they have intronic variants or regulatory variants, or maybe other modifier genes that are changing the ability to read the ALPL, the exons, and letters accurately? For what it's worth, we can also just briefly talk about now, again, nuts and bolts, how do you get genetic testing? So for young patients, there is a Discover Dysplasia panel that includes ALPL through Invitae. This is at no cost, but to be honest and fair, when you read the fine print, you are agreeing to participate in research. Although to be clear, like if you were to find an ALPL variant on this Discover Dysplasia panel, it's not a research finding. These companies are just asking for samples because there are a lot of people with negative genetic testing, right, who have skeletal dysplasias, and so these labs are also in the process of trying to find answers for the population and for those affected individuals. The same company does do single gene ALPL testing. But this company, again, just full disclosure, many of you may have had testing through them when they had more patient-friendly billing that has gone away. So just my pearl is, if you do use this company, request prior authorization ahead of time, because genetic testing can cost upwards of $1,000. And then GeneDx also has a skeletal dysplasia panel, which includes ALPL. We're increasingly using this company just because they have a patient assistance program, and you look at the number of people in the family and the income, and you can pay anywhere between $0 and $250, which in our world of genetics is a very reasonable cost. And then I will also just say here that people are beginning to look for those intronic and regulatory variants. This was a paper that was published just last year with a caveat that it was only 16 individuals, so a very, very, very small number of individuals. For what it's worth, they didn't identify new disease-causing variants. And when they looked at other variants that could be present, I would argue just that these diseases were completely separate. Like some of them have to do with dystonia or abnormal muscle tone. And then the uncertain variants, right, are variants that the lab doesn't know right now with any clarity whether they cause disease or not. So there's a lot of work to do for patients who have negative testing, but at the same time, it is very simple, and I feel like I say this every clinic, but HPP is diagnosed in people with low alk phos that you can't explain otherwise. And many people are intimidated by the fact that they may get negative testing or uncertain testing for their patients. Please don't let that be intimidating. It doesn't mean you don't have the disease. Remember to think about the family because it's genetic. And if you do have positive testing, even if it's uncertain testing, remember, get your family tested, both the alk phos and the genetics, because you could be a family that helps upgrade that classification from uncertain to disease-causing if that variant is tracking with people who have low alkaline phosphatase. And then, of course, monitor for symptoms and discuss treatment for symptomatic individuals. If you were to come to UVA or ask your other providers about these opportunities, the other way to really learn about HPP is through participation in the global registry. And for people who are starting treatment, think about participation in the sub-study, because for as much as I feel like I've learned about HPP since I was in training around 10 years ago, there is still so much that I don't really know how to counsel my patients on or how to answer their questions. And really the way that we arrive at these answers is through participation and pooling all the information from around the world. So I hope from today's talk that we've covered all of these learning objectives, and thank you again for asking me to speak.